Honey, everyone. Good evening. I realize it's evening and that time of year when it is now dark outside at this time of year. So thank you for joining us this evening. And I am thrilled to be introducing Don Davies and his talk, which I am very interested in. And as you probably guessed, we're also recording the session for those of you who are missing it. Can also follow up and watch it at another time. What I want to do right now is just do a brief land acknowledgement and then speak a little bit about the center and some of the work we do, and then introduce Don, and then he can take it away. He's the main character in this story this evening, so I want to give him ample time to share his research and experience in research as well. So first, at York, I guess their Treaty Week is coming up. So I want to acknowledge the multiple treaties that are in this area of, I guess I think about Toronto as being very Great Lakes. So the one that's primarily in the York land acknowledgement is the Dishit-One-Spoon Covenant between the Haudenosaunee and the Anishinaabeg. Again, reminding people that the Haudenosaunee are actually 6 nations. So it's actually an international treaty or covenant and agreement. It's Toronto is home, past, and present to many different Indigenous nations, which I would like to acknowledge. I also like to remind people that we're on these lands and territories, and we benefit from them in different ways, and to think about our role as descendants and future ancestors and how we're going to take care of it so that future generations can also enjoy and benefit, and ideally live in harmony and reciprocity with the natural world. So I will stop there because I can go on and on and on about land acknowledgements, but we do want to hear from Don. So just think about those moments of connecting to Indigenous peoples, getting out to different events like this one in order to learn more about the people in Toronto and other spaces as a way to acknowledge the places that we find ourselves. So with that, I'm going to, Don is very accomplished young Métis scholar, so happy that he joined York. So right now he is a postdoctoral fellow in the Department of Biology at York University. So he's part of that first round of cohorts that are part of the Provost's Indigenous postdoctoral scholars program. So we're thrilled that he agreed to come to York University to continue his research and studies here. He's a proud member of the Manitoba Métis Federation. He has a PhD in neurobiology and behavior from the University of Saskatchewan. Yes, I'm really into neurobiology right now, so I'd like to just pick your brain about some things. So he previously conducted research as a postdoctoral researcher at the St. Boniface Hospital in Winnipeg and the Kiwi Patchell Evans Autism Research Group. He has a number of peer-reviewed publications, so he's getting his work out there. He also works with the Manitoba Métis Federation, where he examines caregivers of people with dementia. Today, he'll be speaking about his current research on dementia in the Canadian Indigenous population. So his talk is, as you see on screen, Amplifying Indigenous Voices in Dementia Caregivers. I'd also like to welcome Brock Pitawanakwit's class, Professor Pitawanakwit's class, I believe, Indigenous Research Methods. So this is a great talk to learn a lot of the times Indigenous research methods, which I also teach in the Faculty of Environmental and Urban Change, is focuses a lot often on social science methods and qualitative methods. So it'll be great to hear about Don's experience in his current research as well, to hear how this how we're dealing with this important topic. Before we joined, we were just noting that although we primarily think about Indigenous peoples as being a very young population when you think about statistics, but actually it's also an aging population. So this topic is really important in terms of what's happening in Indigenous societies and how to respond to how the demographics is changing over time. So I want to thank Natalie for coordinating and for you for joining and others for joining this session. So I didn't introduce myself. So I'm Deborah McGregor. I am the director of the newly formed Centre for Indigenous Knowledges and Languages. I'm also an associate professor at Osgoode Hall Law School in Faculty of Environmental and Urban Change. Delighted to be introducing Dawn. And the Centre for Indigenous Knowledges and Languages is essentially trying to, like this presentation, amplify Indigenous research. What does it look like? Amplify the voice of Indigenous researchers and non-Indigenous researchers and allies who engage Indigenous research. Supporting of graduate students. Dr. Pitawanakwit's very much involved in support for graduate students in Indigenous research, thinking about careers in Indigenous research. We're having a speaker series of Indigenous scholars at York University, which Natalie is coordinating. We've had one already, and there's more coming up, which she can speak to at the end of this talk, just to bring your attention to maybe some of the others that are coming. And happy that you're here. And if you have ideas for other topics that you might like to hear about, or other topics relating to the center or Indigenous research, we're happy to hear them, and we'll see if we can accommodate them. I also wanted to give a shout out also to Dr. Pitawanakwit. He's an associate director also at the Center for Indigenous Knowledges and Languages. So with that, I welcome you, Dawn, to begin your presentation. And again, first of all, or second of all, Chimigwech for joining us on a Monday evening and sharing your research. Chimigwech.
Yeah, thanks for the introduction. Yeah, so as mentioned, I'll be talking about amplifying Indigenous voices in dementia caregivers. Dementia is a worldwide epidemic. So worldwide, around 55 million people have dementia, according to the WHO, and over 500,000 Canadians are living with dementia today. And close to 1 million Canadians will have dementia in 2030, which is predicted by the Alzheimer's Society of Canada. And individuals can improve their lives through early diagnosis to optimize available treatment. So dementia is composed of many neurodegenerative disorders. It's this dementia is an umbrella term for chronic and progressive conditions of deteriorating cognitive function, which affect daily functioning. So Alzheimer's disease is the most common form of dementia. Also, there's vasculature dementia, Lewy body dementia, frontal temporal dementia, Parkinson's disease dementia. This is not an exhaustive list. There's other forms of dementia, but these are some of the most common forms of dementia. So dementia is higher in the Indigenous population. In Canada, it is 34% higher, and an average age of onset is 10 years younger in Indigenous Canadians. It's 21% higher in the Indigenous Australians, and 35% greater risk of developing dementia in Indigenous populations in the US than non-Latino whites of dementia over the 25-year period after the age of 65. So who are the Métis people, since this is the group that I'm currently working with? So the Red River settlement in Manitoba is widely recognized as the birthplace of the Métis Nation. So the Red River settlement is Winnipeg, what is now known as Winnipeg, Manitoba, and some of the northern portion and southern portion of Winnipeg and southern areas south of Winnipeg. So American settlers took over this land in the 1870s. They forced the Métis population off the land, and if the Métis didn't relocate, they killed them. So this forced the Métis population to disperse from the Red River settlement, mostly northwest, and some more just west into the Saskatchewan, Alberta territories. But we saw this, the Métis people lived on Crown land adjacent to reserves. So you had the First Nation reserves, and then the European settlements, but the Métis had to make their own dwellings, and these were precarious dwellings, usually without fixed addresses. So this lack of fixed address prevented access to education for Métis children, because they could not register their children for education. And the ones that could register their children for education usually went to residential schools. And also they couldn't open a bank account because they didn't have a fixed address. And this was largely abolished in the 1960s, 1970s. However, Métis people are still living on Crown land in various parts of Manitoba. And actually, one of the things that, like, I give an honorarium for dementia caregivers to speak to me, and one of the challenges is if they don't have a bank account to give cash into their hands. So just planning the protocol around this to make it as inclusive as possible. So the Métis were denied a separate identity and ignored for a century. So from the 1870s, really until the late 1960s, 1970s. So in 1967, with the formation of the Manitoba Métis Federation, the Métis in Manitoba were again asserting their capacity to advocate and function once more in a collective manner. So the Métis make up 36% of Indigenous peoples in Canada, numbering over 600,000 in 2021. So it's a fairly large number, and more than 18% of Métis in Canada live in Manitoba, with over 10% in Winnipeg alone. So the history of the Métis people is long and complex and under-recognized within Canadian research, programming, and policy. For instance, access to formal health, formal caregivers, such as home care, is not subsidized for Métis people in Manitoba, whereas First Nation and Inuit people in Manitoba have home care and these formal healthcare supports that are subsidized. The Métis are recognized as a unique nation with their own language, tradition, and culture that emerged initially through the blend of Indigenous and European settler traditions. Many Métis people have hidden their identity, often in partial response to mitigate potential discrimination associated with being visibly Indigenous. And Métis health is poorer than non-Métis people. So there's several different studies that show this. So the health of Métis in Canada lag behind that of other Canadians, and the Aboriginal Peoples Survey reported a higher prevalence of chronic diseases in the Métis population in Canada. So with the Manitoba Métis population specifically, they have a higher rate of mortality. So the Manitoba Métis population have higher premature mortality rates than all other Manitobans. And the injury mortality rate for Manitoba Métis is higher. So vehicle accidents, choking, poisoning, drowning, etc. those rates are higher in Manitoba Métis compared to other Manitobans, and the life expectancy at birth is lower for Manitoba Métis males compared to all other Manitoban males. And Manitoba Métis with diabetes are significantly more likely to die within a 5-year period than all other Manitobans with diabetes. So Manitoba Métis have higher rates of physical illness, so they have higher rates of hypertension, total respiratory morbidity, so a lot of lung conditions, diabetes, stroke, dialysis, so impaired kidney functioning, ischemic heart disease, and Manitoba Métis have lower limb amputations, a higher probability that they'll have lower limb amputations related to diabetic complications. And Manitoba Métis have higher rates of mental illness, so anxiety disorders such as phobic disorders or obsessive compulsive disorders are increased in the Manitoba Métis compared to all other Manitobans, and same with substance abuse, which is defined as excessive use and reliance on a drug, alcohol, or other chemicals that lead to severe negative effects on the individual's health and well-being or to the welfare of others. And personality disorders are higher in the Manitoba Métis population. So this causes serious personal and social difficulties, as well as a general impairment in functioning. And also with children, the Manitoba Métis children have poorer health outcomes. So child injury mortality is increased in the Manitoba Métis population. And the two biggest factors were the external cause. So usually injuries like motor vehicle accidents, drownings, poisoning, that sort of external cause, and cancer as well. And the Manitoba Métis also have increased attention deficit hyperactivity disorder, which is a neurobehavioral developmental disorder that typically presents during childhood and is characterized by a persistent pattern of impulsiveness and inattention. And the Manitoba Métis population have higher rates of surgery. So cardiac catheterization, so this is usually done if you have an abnormal heart rhythm like atrial fibrillation and coronary artery bypass graft. And in females, Manitoba Métis females had higher rates of hysterectomies compared to all other Manitoban females. And the Manitoba Métis use physician services more often. So ambulatory visits are increased in the Métis population, which is an indicator of overall poorer health status in the Métis population. So the most common visits were for respiratory, circulatory, musculoskeletal, and the nervous system. So Métis people had at least one physician visit per year. However, Métis are less likely to have continuity of care. It may be due to the lack of family doctors for the Métis, so the continuity of care, having that one healthcare provider manage all of the health of a Métis is not there compared to other Manitobans. And also, Manitoba Métis use hospital services more often. So there's an increase of hospital separation rate, which possibly reflects the poor overall health status of Métis. So separation from the hospital occurs anytime a patient leaves because of death, discharge from the hospital, or transfer. So Métis injury hospitalization rates are higher than those for all other Manitobans. So for the Métis, the top causes are accidental falls, homicide and injuries inflicted by others, suicide and self-inflicted injury, and motor vehicle accident. So the Manitoba Métis also have higher prescription use. So antidepressants, which are used to treat depression, mood, and anxiety disorders. They have higher rates of antipsychotic prescription use, so to treat psychosis and other psychiatric disorders. The Manitoba Métis have higher antibiotic use, and the Métis have higher benzodiazepine use to treat anxiety disorders, panic disorders, insomnia, seizure, muscle spasticity, and alcohol withdrawal. Métis have more prescriptions in 1 year and a greater daily dose of those benzodiazepines. And Manitoba Métis have poorer health practices. So when the Métis, all the people in Manitoba were asked to self-rate their health, the Métis people self-rated their health as poor compared to other Manitobans. And the Métis people have lower consumption of fruits and vegetables. The Métis have higher alcohol consumption, higher smoking rates, higher exposure to smoke in the house, so the second-hand smoke from other smokers in the house. And Manitoba Métis are at higher risk of being overweight or being obese. And the Métis youth have higher rates of smoking, drinking, and sexual behavior. So understanding patient culture is key for health outcomes. So culture is shown to influence experiences with illness. So without understanding Métis culture, it's not possible to develop appropriate mechanisms for diagnosis, treatment, and care. And what my research program focuses on is that last part, the care part. So we talked about a lot of other disorders, but now we'll talk about dementia in the Manitoba Métis population. So there's higher rates of dementia for the Métis compared to all other Manitobans. And these rates also vary as a function of sub-region within this province. So Manitoba is pictured there in the map in red. It's the center of Canada. So in terms of regional dementia rates in Manitoba for those 55 and over, Brandon has increased dementia rates in the Métis compared to non-Métis. And you can see with that gold star, that's where Brandon is, which is the second largest city in Manitoba. In the rural south, you can see just south of Winnipeg, also the Métis have higher dementia rates compared to non-Métis. And in the mid-province area or the Interlake region, the Métis also have increased dementia rates compared to non-Métis. And then finally, River Heights, which is a community area within Winnipeg, the Métis actually have this doubling of almost double dementia rates compared to the non-Métis in that area. So informal caregivers are essential in Canada. So what are informal caregivers? So they're unpaid caregivers. Usually they're partners, adult children, daughters or sons-in-law, or other family and friends. In Canada, most informal caregivers are 45 years or older. So this can lead, so some of these caregivers have chronic health conditions themselves, which can lead to caregiver burnout. So informal caregiving reduces the health across multiple domains. So caregivers are more likely to be diagnosed with major depression, anxiety disorders, other physical morbidities, and a higher rate of premature mortality. So stress drives this reduction of health in informal caregivers. So the informal nature of this care means that most caregivers have little or no training. And in some cases, it may require 24 hours a day of vigilance. So if you think of something like we mentioned before, Alzheimer's disease, a lot of times these patients have impaired circadian rhythm. So they wake up a lot during the night and may wander off from the bedroom, and the caregiver has to be up and guide them back to their room. So this is happening every night. So these factors multiply stressors, negatively impacting physical, emotional, and psychological health. There's also cost of care and reduced capacity to work or pursue financial gain, which compounds the stress. So often caregivers have to reduce their workload and sacrifice how much money they're getting, or outright quit their job to provide care. So despite formal supports for informal Manitoba Métis caregivers, informal caregivers are forced to supplement services or to compensate, that is pay for the formal caregiving support. So whereas First Nation and Inuit people in Manitoba are able to have this formal support subsidized, the Manitoba Métis caregivers cannot have this the formal caregiving support subsidized and have to pay out of pocket. Also, there's no up-to-date information about informal caregivers in the Manitoba Métis community. So without informal caregivers, patients would have a poorer quality of life and require institutionalized placement, resulting in the cost to the healthcare system. So the heavy burden of disease in Métis, coupled with an aging population, has led to an increased reliance on informal caregivers. So rural Métis caregivers may have to deal with additional burdens, such as lack of clean water and lack of running water. They may have to heat their property using a wood burning stove, therefore chopping down trees and preparing the wood for burning, like all while taking care of someone with dementia. In many places, there's a lack of electricity and lack of formal caregivers in these rural Métis communities. And even when there are formal caregivers in these rural Métis communities, they do not go into houses that have lack of drinking water, or a lack of running water, or a lack of electricity. So if they don't have these, if they don't have running water or electricity, you cannot get a formal caregiver. So it creates this other barrier and burden for the informal caregiver to shoulder. So we developed this program after Métis citizens reviewed the outcomes of Métis aging in place and informal Métis caregivers of Métis seniors. So this was a research project that looked at all types of informal caregivers. So people that were caring for seniors with cancer, with musculoskeletal problems, with cancer, MS, stroke, and dementia as well. So what they found was that this study indicated that Métis caregivers of those with dementia were suffering as a result of unmet needs. So, however, major gaps exist in our understanding of caregiving outcomes for caregivers and those they care for in the Métis community. So I approached the Manitoba Métis Federation to form this knowledge translational partnership between three organizations. So Francis Chartrand is the Minister of Health and Wellness at the Manitoba Métis Federation, and she really gave me access to this community, the Métis community. Even though I'm in the community and connect with a lot of people, she gave me access to all of Manitoba, all the regions of Manitoba. And Dr. Julianne Sangens in the Department of Community Health Sciences at the University of Manitoba has been doing this qualitative research, community participatory research for many, many years in the Métis community. So she was really a great expert and collaborator to rely on. And then myself being in the Department of Biology at York University. So we created this tripartite partnership. So just to go back and talk about the Manitoba Métis Federation. So it's is one of the most established governance structures for Métis citizens within Canada. So it promotes, protects, and advances the political, social, and economic interests of Métis. So the MMF negotiates with provincial and federal governments to access funding to provide a wide range of programs and services for its citizens, which is very important when we talk about external stakeholders such as Manitoba Health, what we would call in Ontario as OHIP. So Manitoba Health would be the ones that really form the policies. And it's great that I have this network now with the Manitoba Métis Federation, who also knows Manitoba Health and can influence policy. So the MMF received its first historic funding transfer in 2018 when the Government of Canada formally recognized the MMF as the legal self-government for Métis citizens in Manitoba. Now, within the Manitoba Métis Federation, there's the Health and Wellness Department, which plays a leadership role in its vision of a well Métis community. So developing and using knowledge that is based in Métis culture is holistic in perspective, as advanced through the Métis Life Promotion Framework and advances healthcare capacity. So the primary goals of the Manitoba Métis Federation Health and Wellness Department is to enhance Manitoba Métis Federation capacity to lead extraordinary and concurrent interventions to assure improvements of Métis health status and healthcare programs and services and service use that are in line with the provincial health system. So this is the stages of my research program. So the first is protocol for entry into the community. Second is initial data collection and analysis to gain breadth of information of informal Métis caregivers' experiences. Third is co-learning through subsequent data collection and analysis. 4 is meaning making and contextualizing our findings. 5 is intervention. 6 is evaluation. 7 is implementation of science through knowledge networks and beyond. And also, I aim to build capacity among Indigenous scholars or students in dementia research. So I currently have a research assistant from the Manitoba Métis Federation who will be conducting these interviews. And I aim to recruit more Indigenous scholars and students on this research program. So our overarching goal will facilitate relationships among Indigenous communities to advance dementia caregiving research. And so what I use is this community-based participatory research. So it's this collaborative approach that equitably involves all partners in the research. So informal Métis caregivers in Manitoba, and it's used throughout all the stages, so stages 1 through 7, and it benefits the community by translating the knowledge gained in the research into intervention and policy change. So it's used to create social change, build relationships based on trust, and improve the quality of life. And pictured there, you can see the tripartite relationship between the Manitoba Métis Federation, the University of Manitoba, and York University, with arrows pointing to each other, just representing the talking or dialogue that is going back, and this collaborative approach for the community-based participatory research. So community-based participatory research has a cooperative focus. So it engages community members and researchers in a joint process in which they contribute equally. So it's conducive to co-learning and capacity building process. So empowering to community partners. So we want the knowledge that can be put into action and drive policy change. So the Métis community will assist in every phase of the project, from selecting study sites to recruiting participants, to analyzing the data and interpreting the data. So these are stages 2, 3, and 4. The community-based participatory research will be used to collect information about needs and ideas for programs. And this is the later stages, so 5, 6, and 7. So I'll be working with the Métis to build this Métis knowledge and conducting key informant interviews with informal Métis caregivers of those with dementia, and interviews with Métis seniors with dementia to create a historical context for care of Métis with dementia. So we're using a flexible interview structure to optimize knowledge gathering and increase the scope of the interview yield. So it's really open-ended questions to get rich data, qualitative data. And the Métis interviews are based on the wellness areas. So the questions that we will be asking, most of them are based on this wellness wheel. So the Health and Wellness Department employs a holistic model to collect and organize information. So the wellness areas flow around the spokes of a red river cart, representing constant motion and change. So here's the questions, some of the questions that I'll be asking those informal caregivers. So you can see number 1 is nature, so sense of who I really am as a person. Number 2 is identity, experience of how others see me or how I want others to see me. 3 is development, so sense of age, ability to express the child, youth, adult, and elder parts of me. 4 is relationship, so ability to respect and care for others. 5 is network, so ability to interact with others. 6 is support, so body ability to work and be involved in community. 7 is environment, culture, social, economic, and political influence. 8 is governance, ability to choose my destiny and future. So in addition to these questions, we'll also have questions related specifically to dementia caregiving. So interviews will have a broad opening question asking people to comment on what they find most rewarding and most challenging in providing care for a family member with dementia. And we want to learn about the current status of caregiver burnout. And we want to know the amount of supports that the caregiver currently has and the amount of support that the caregiver would need to live comfortably with the senior with dementia that they are supporting. So this is just going back to the stages of the research program. So I'll break each one down. So the first one, protocol for entry into communities. So this stage of research seeks to reconfirm commitment and respectful engagement. So a letter of support has already been secured from the Manitoba Métis Federation Minister of Health and Wellness, Francis Chartrand, and ethics have been approved. So I'm currently in the second stage right now. So the initial data collection and analysis to gain breadth of informal Métis caregivers experiences. So this just started this month. So, and I anticipate that this phase will go until February 2023. So interviews are being conducted with informal Métis caregivers of individuals living with dementia, and I predict significant differences between rural and urban experiences of caregivers. And then the interviews with these informal caregivers will be in each of the 7 Manitoba Métis Federation regions. So you can see the Thompson region, the Northwest region, Interlake, Southeast region, the PA, Southwest region, and Winnipeg. So each of these regions, I expect will give different data, different experiences from the caregiver. So to help with the incorporation of Métis knowledge, the research team will conduct further data analysis using the collective consensual data analytic procedure. So this has been used and identified as well suited to qualitative research in Métis health research. So Métis members assist in the expression of the social, historical, and political contexts that shape the Métis experience. So we are creating Métis specific knowledge. The third stage is co-learning through subsequent data collection and analysis. So this will take place approximately February to April 2023. So by then we'll have a summary of the key themes and ideas that were generated from the earlier interviews. So this allows us to do 2 things. So first, it allows us to share our emerging interpretations to other Métis and formal caregivers. Participants will be able to identify if these earlier interviews have adequately captured experiences. And the second thing it allows us to do is to capture any experiences not already captured and gain a better understanding of Métis informal caregivers in other locations of Manitoba. So the fourth stage is meaning making and contextualizing our findings. So this will take place approximately between May and June 2023. So We'll have the analysis of themes to identify patterns and trends across Manitoba. And it allows comparisons of experiences across the entire spectrum of caregiving and any regional variations. So, for instance, the North and South, or Winnipeg and northern remote regions, and then interventions will arise to be implemented in stage 5. So the 5th stage is intervention. So this will take place from approximately July 2023 to December 2025. So interventions and programming will be developed and implemented by community wellness workers from the Health and Wellness Department at the Manitoba Métis Federation. So these community wellness workers are already working in the community on a range of different educational programs like diabetes, addiction, mental health, and we can train them for dementia. So these interventions will consist of psychosocial, psychoeducational services, and behavioral interventions. So one of the things that we've been talking about now is to do an educational component to recognize early signs of mild cognitive impairment in Métis population, because a lot of people, Métis population, don't recognize early signs of mild cognitive impairment and believe it's just a normal part of aging, rather than identifying it as something that needs to be addressed by a doctor and looked into further. So the 6th stage is evaluation. So this is constantly ongoing. So there'll be initial, midterm, and summative evaluations. So the goal is to examine if the policy changes are working. So I'm currently working with the Manitoba Métis Federation to develop a tool for conducting these follow-up evaluations. And the last stage is implementation of science through knowledge networks and beyond. So this will allow members the opportunity to provide us with critical feedback to ensure we collect policy relevant data that could inform programs delivered to Métis population. So a final report will be written about the study, and preliminary results will be taken back to the community and disseminated back to the community via social media through the Manitoba Métis Federation and through community dinners across different regions in the Manitoba Métis Federation. And also we'll be talking to Manitoba Health and Manitoba Health Seniors and Active Living, which are two governmental organizations that that the Manitoba Métis Federation currently has ties to, but these will be external stakeholders that will be able to inform policy and create policy at this stage. So in terms of outcomes and deliverables, so identify the experiences of Métis caregivers and Métis with dementia, and to have this dialogue with community members to break down barriers and improve quality of life for informal Métis caregivers, and to have the dialogue with external stakeholders such as Manitoba Health to identify strategies that help ease burdens associated with Métis informal caregiving, and governing Métis organizations across Canada, such as Quebec, Ontario, Saskatchewan, Alberta, and British Columbia, will be interested in the themes identified from this work. And this creates Métis specific knowledge, which is underrepresented and underpublished currently. And Also, several impactful academic papers are planned with the goal of describing the experiences of informal caregivers of individuals with dementia and outlining regional differences of interest and importance. So, as I mentioned, the rural versus urban differences, and assessing the effectiveness of culturally informed approach. So to always have these evaluations ongoing, and making sure that we're collecting policy relevant data, and the use of implementation science platform for knowledge translation and influencing policy development. So in terms of methodological issues and limitations, so the data collection will be conducted in English. So there may be barriers to participate for Métis who are more comfortable speaking one of the traditional languages, such as Cree Michif, French Michif, Cree and OG Cree, and other Indigenous languages. So that's creates a barrier to participation. Participants will not be asked to demonstrate Métis status through the presentation of citizenship cards. So the citizenship card is kind of this extensive process to prove that you are Métis, so we're not asking for that. So the study, as a result, the study participants may not fall under the official definition of Métis citizenship. And but the recruitment is conducted through the Manitoba Métis Federation. So all family caregivers indicate some level of Métis, level of involvement in the Métis Nation in order to participate in this study. And then I'd just like to end with the acknowledgements of Dr. Julianne Sangins at the Department of Community Health Sciences at the University of Manitoba, who has been doing similar types of research, health research in the Métis population for many years, and has been great on this project, guiding me through this qualitative community-based participatory research. And also thanks to Francis Chartrand, who's the Minister of Health and Wellness at the Manitoba Métis Federation, for giving me access to the population and the support for this to get the project off the ground. And Dr. Stephen Connor in the Department of Biology at York University, who's helped with this project as well. And also to the funding sources at York University to financially get this project off the ground and rolling. And then here's just some of the references I mentioned throughout the talk. And now I'd be happy to take any questions.
Thanks, Don. Maybe I'll just, there is a question in the chat if we want to start there. Brock or someone in his class wanted to ask about the timelines for stages 6 and 7. How do you envision that going?
Yeah, so yeah, that will be after my postdoc concludes. So just to refresh my memory, stages 6 and 7. So yeah, evaluations. So yeah, that's one of the things I'm currently working on with the Manitoba Métis Federation about developing a tool for conducting evaluations. And the overarching theme is to have policy relevant or collect policy relevant data in order to drive policy change. So given that we're still in the early days, the tool is still being created for how that evaluation will take place. So I'm not exactly sure. And then the implementation of science through knowledge networks and beyond. I think that will really depend on interfacing with Manitoba Health, since they are provincial governmental levels. And once we have that data, especially the initial data collection, perhaps can really form some of the implementation of science, and also using the community wellness workers at the Manitoba Métis Federation to inform different educational programs and perhaps create different policy. Yeah, it's still kind of really early days, so I know this talk was kind of broad, especially number 6 and 7 was kind of broad, but I think once we have the full initial data collection, I think then it will be more clear in steps 6 and 7.
Great, Don. I think you can see the comment. So it sounds like that was very helpful. I know there's a few in the chat. Is there anyone who has a question? Virtual first, then we'll go over to the chat again.
I'll just because I have to leave in a few minutes to travel. But thank you for that, Dawn. And I agree. This will generate knowledge. I like the fact that it's an Indigenous, Métis led by yourself and the Métis Federation. But I was curious about a couple things. One is, if you wanted to comment on why dementia is higher in Indigenous populations, maybe it's part of the social determinants of health, or it's part of the health disparities. And the reason I ask, because I may have missed it, because this was a very there was a lot of content in this presentation, so I may have missed it, is whether the caregivers are also primarily Indigenous people, because that means they're also already at risk for dementia, right? Because that's sort of what the statistical data is showing. So whether that's the case, and if so, then on top of the other health issues that tend to arise that you pointed out, are they already at risk in the first place because they might be Indigenous? The other one that I found really curious, because I know it's very contentious in Métis community, is how you came up with the inclusion criteria for, actually think it's quite clever to not ask for the card, but to say who's involved with the Métis community. Like, that's a very interesting way of sort of working around that question. So I'm wondering where that came from, if that's already a process that the Métis Federation already uses in health, or whether that's something different. I just thought it was a very clever way of sort of not excluding people. So I thought it was an interesting, like, in terms of ethics, the inclusion criteria. I know I'm throwing a lot at you, but but I want to commend you for the Métis-led research that's going to result in specific Métis knowledge, because you're right, there's not a lot out there.
Yeah. So with the whole, I guess, card thing, or not asking for people's citizenship card, I was told that was what they had done before. Like the University of Manitoba researcher, Dr. Julianne Sangens, has been doing that for many years in her studies. That says as long as they have some affiliation to the Manitoba Métis Federation, then they will include it. So and to go back, I guess, to one of your earlier points about so the person with dementia is Métis, and then the spouse or the caregiver, informal caregiver, may not be Métis, and usually what we see from other studies is that there's several caregivers. Perhaps there might be a spouse, a son or daughter, like adult son or daughter, and then a friend, So there might be several people involved with the care of one person, one senior with dementia, and maybe some of them are Métis themselves, and some of them aren't Métis. But yeah, for the study, we try to recruit the person that is Métis, and kind of assume that the caregiver is also Métis. But yeah, we don't confirm it with citizenship cards, or really even ask them, as long as they have some affiliation with the Manitoba Métis Federation.
Thanks, Dawn. I'm going to jump to a question from Brock or his class in the chat. Will there be any interviews with dementia patients at any stage, or only with their caregivers and the key informant interviews?
Yeah, so I want to do interviews with some of the seniors with dementia. We won't be doing it as much with the seniors with dementia. The primary focus is for the informal caregivers, but we do want to have a few, we talked about it, me and my collaborators talked about it before, to have at least one Métis with dementia from each region. So overall, it would be 7 people, but that's not the main focus of the project. To create this historical record of Métis specific knowledge of people with dementia and their experiences and knowledge with dementia.
Looks like there's another one in the chat. I don't know if it's helpful that I read them. I think you could probably read them yourself. Oh, 2.
Okay. So yeah, early in your presentation, you gave an overview of Métis Health. Is all your data based off self-identification or Métis membership? Where did the data come from? Yeah, so that data, I believe, and I was referencing other papers, so I didn't, so in the early part of the talk, when I was referencing other papers, I believe this was like self-identification of Métis, so they didn't have to prove their Métis-ness or confirm with the citizenship card. I can read the other one. I'm curious, perhaps this pattern will emerge in the course of research about the urban-rural divide and the higher percentage recorded in Winnipeg. Are families moving to town to access better services support, or are they more likely to be diagnosed if they live in town? Yeah. I think they are more likely to be diagnosed if they live in town, just because knowing the rural population and the lack of healthcare or healthcare providers in the rural population. I don't have data to support this, but like kind of anecdotally, I would almost suspect that the rural population has higher prevalence, or that they're underreported. And if they go into these big city centers like Winnipeg, they will have access to better supports and services than remote areas. And especially if the remote people do not have electricity or lack of heat or running water, they are not eligible for these formal supports. So yeah, I think families are perhaps moving to Winnipeg or other cities like Brandon in Manitoba to access these better supports.
Don, I have a couple of questions for you, if you don't mind. I have two. My first question is, I guess stepping back, I'm curious how, because I read a little bit about your bio and your background. I'm curious how you, why you, what got you interested in this topic and this group. Yeah, the Manitoba Métis, and I guess also why Manitoba is kind of part of my question as well. As you mentioned, they live across Canada, but why specifically this community?
Yeah, so in terms of my interest in the project, like when I got into science in general, I was always interested in making an impact, having like a real world change, and spent a lot of years doing lab work and looking at molecular mechanisms of different like cellular biology, and was publishing papers, but I didn't feel like I was really making an impact. So I think this was a very nice career transition to go into this way and pick this project, which definitely has potential to be impactful and have policy change with Manitoba Health and the Manitoba Métis Federation to have access to money and policy formation. So yeah, that would be the reason that I chose it. And then in terms of going to the Manitoba Métis Federation, just because I grew up there, basically, it was the community I was most connected to. So that's the reason why I chose it. And I've been going to conferences from the Manitoba Métis Federation for many years. And yeah, one thing I always noticed about those conferences is how across a wide span of health parameters, the Métis perform poor. So I thought this would be a great community where I could hopefully have some impact. And it's, I guess, kind of personal because it's my community. So just makes that project all the more like passionate for me to make a impactful difference.
Thanks for sharing. Maybe we'll just give a little space in case, as I recognize there's a few students in Brock's class who might have a question but are listening intently. Maybe I'll give them a chance if they have a question, because Brock will have to type it up. So we'll give them a second if any of them have questions to pass them to Brock. Okay. Okay, we're good. Okay. This is a new experience for us, having a class, but not being able to see or hear them. So are there any other questions? I think I'm going to ask one more, if you don't mind, Don. Can you speak a little bit about co-learning? I found that a very interesting concept. Is that something that is spoken a lot about in the sciences, or yeah, like just as a research method? Can you speak a bit more about that?
Yeah, so yeah, that research method, it really gives agency to the population that's being studied. So in this case, the Métis population. So once the interviews are complete, they will be transcribed, and then key points will be categorized So, for example, some previous papers have shown that there might be language barriers because some Métis population want to speak Cree or Mischief, and healthcare providers, typically in Winnipeg, can't speak that language. So we categorize it all into, perhaps language barriers, and so then various people in the community will come to, whether that be elders or the caregivers themselves, will look at the patterns that me or other researchers have identified, and either say that's incredibly accurate, or maybe, or no, that doesn't really represent Métis knowledge and shouldn't be included. So it's really this collaborative approach between the Métis, everybody in the Métis population, and the researchers, and I guess the tripartite relationship between York University, University of Manitoba, and Manitoba Métis Federation, and the people there, and really allowing the Manitoba Métis community to have the final say on what is considered a true pattern in the data after it's all transcribed, and all the patterns have emerged, whether the pattern is true or not.
Thank you. I think those are all our questions. So I think I will, maybe everyone can join me in thanking Don for his wonderful presentation. And I will just note we have this presentation is part of a series we are doing, the Center for Indigenous Knowledges and Languages Research Seminars. We have another one tomorrow at noon, and that's Graham Reed speaking about Indigenous climate futures, alternative visions for nature-based solutions. And we also will have another seminar at this time. Dr. Edward Doolittle will be visiting us on November 7th. And his specialty is in math. So we're learning from all different kinds of people involved in all different kinds of research. So again, thank you so much, Don, and I wish you all the best with your research. We look forward to hearing more about it.
Thank you.
Thanks everyone for coming.